volunteer time to participate in the Early Intervention Task Force meeting today. And I think this is a very important meeting for us. I'm Susan Buttress. I'm a developmental and behavioral pediatrician at the University of Mississippi and the chair of this task force full of great experts and advisors who will be helping us in stepping through this. I thought I would make a couple of quick comments about the fact that this task force, in my mind, is one that is very, very important because it is targeting looking at services for very young children and to that end, the services for these very young children that are in their early developmental stages are very important. To find children who are at risk and in need of services, to intervene early is the best investment we can make in our state. It is the best, not just for children, but for the economy. And so to that end, I feel like we've got a very important job. I'm very thankful to the legislature and our governor and lieutenant governor for forming this because I think they recognize that this was something important that needed more focus. And I'll say one more thing. I think it's very clear to all of us that there are numerous reasons that this task force was formed and that we needed to get together and decide how we can help. And we'll go over those reasons as we're moving forward. We do know that we need a deeper investment, but we have to make sure that it's an investment that is well thought out, well organized, and will give us a good return on our money. So I'll stop there. And with that, I'm going to ask Mary Claire to do roll call for us.
We know Dr. Buttress is here, Representative Richard Bennett. And I just say, I think if you're up. Your microphone. That might help. Can everyone hear me if I just yell like this? Just go like this, okay. If you're on Zoom, please just say here or just identify that you're here if you are here. Representative Richard Bennett, Senator Hob Bryan, Senator Nicole Boyd.
Here.
Ms. Kay Carr, Ms. Miranda Carter, Dr. Daniel Edney.
Here.
Representative Kevin Felsher.
Here.
Dr. Tanya Fitz. Dr. Heather Hanna.
Here.
Ms. Biz Harris. Dr. Carlin Hennington. Senator Chris Johnson. Ms. Leslie Junkin. Dr. Sophia Leggett. Senator Tyler McCon. Representative Sam Mims. Dr. Denise Powell.
Here.
Representative John Reed, Dr. Courtney Walker,
Here.
Mr. Keith McCannon,
Here.
and these are our advisors, Dr. Julie Parker,
Here.
Dr. Kenya Wolf,
Here.
Miss Penny Manziel,
Here.
Dr. Catherine Cassidy, Dr. LaShonda Carson,
Here.
thank you, Dr. Candace Carter Stevens,
Here.
Dr. William Brown, and Miss Sarah Myers. And then we also have a guest presenter, Dr. Alicia Westbrook.
Here.
I'm sorry. Can you hear me? Could those online hear me? You could? Okay. So. Okay. I'll just repeat myself very quickly. Dr. Edney will have all the time that he needs since the early intervention program is housed in his department. And then we'll get to our other presenters who will be limited to 10 minutes. So with that, I'll turn it over to our Chief Medical Officer at the Health Department, Dr. Dan Edney. And thank you, Dr. Edney. I know you're at another meeting and had to step out. We appreciate you being here.
Thank you, Dr. Buttress, and thank you, everybody serving on the task force, and for giving me an opportunity to share my mind and my heart with you in terms of the important work of the early intervention program. And just a quick introduction for those of you who've not gotten to know me. I'm completing my first year as your state health officer. And as you can imagine, it's been a very steep learning curve this year with not only our normal work, such as EI being so important, but also having 13 unique public health challenges come at us outside of our normal scope of work through the last year. But having said that, the work of the early intervention program as it interacts with all of y'all in providing the much needed resources for our children and families who need it in Mississippi is so very important to me. I came to the health department about 3 years ago in the midst of the pandemic to be the first chief medical officer for Dr. Dobbs, and then succeeded him when he stepped down to go to academics. But I come from over 30 years of private practice in Vicksburg and being deeply embedded in my local community in West Mississippi and caring about the needs of patients across the spectrum. I'm also the father of 3 children who are now adults, and one of which had a significant learning disability, which she overcame and with expert attention. And I'm the grandfather of 3.8 grandchildren, of which I pray for their growth and development literally every day. So this is, although I'm an internist and addiction medicine specialist, and this was not part of my professional life, it's very near and dear to my heart as a physician, father, and grandfather. So I appreciate the opportunity to work with expertise that's vastly represented on the task force so that I can continue to learn from you as we leverage your expertise and also our resources at the health department towards building a stronger and better EI program purely for the benefit of our children and families who need it. And I know we all have the same focus here. And I'm committing to you, Dr. Buttress, that my only intent as we go through this important work is how do we make this program better and stronger and provide better services faster and more efficiently for the children and families that need it. So there are a few guiding principles for our work at the health department while I serve as your state health officer, and they're pretty simple. I didn't leave private practice to have the opportunity to run a large state agency, but rather I felt a calling to leave private practice and to have the opportunity to use the resources at the Mississippi State Department of Health to help make things better for all Mississippians, which is our mission, to advance and protect the health, safety, and well-being of everyone in Mississippi. That's a large, very broad mission, but it's one that I take seriously and that those of us at the health department take very seriously, as does the Board of Health. And I truly believe that the Mississippi State Department of Health is a force for good when it comes to the health issues of all Mississippians. And we're the agency that cares about the health issues of every Mississippian. And it will be for early intervention as long as I'm the state health officer. As a well-trained physician, Dr. Buttress, you and I had talked about this. We know we were trained early and often to know what you don't know. In other words, don't be an expert in things which you're not. And I'm obviously not an expert in early childhood development. And so my approach to all of the programs that we run and all the things that we regulate is that there are core public health issues that we are the experts in the room for. And then there are many really important programs that we rely on the expertise of those in the field who have it. And my philosophy will always be, in those circumstances, to rely on our advisory groups, which we have throughout the agency in many different areas. And CCAC is a very important advisory group for us. And in those opportunities, when we have thoughtful recommendations from our advisory groups, it is my expectation that our programs will listen to those advisory groups and, to the best of our ability, follow through with recommendations as they come from the advisory groups. Advisory groups for me are not just busy work to check a box off on a federal grant, but they are there to help us do our jobs better, to make sure that we're providing Mississippians with what they need. The only caveats to this, and I hope you'll agree with me on this, that being said, is that there needs to be solid consensus on those recommendations. There needs to be no perceived demonstrated self-interest being promoted by any organization or individuals. There needs to be reasonable evidence supporting the recommendations. Our federal project officers have to obviously be willing to allow it. And principally, above all things, that whatever we do will improve the access to care and outcomes for the children and families that we all serve. And having reviewed CCAC's recommendations, been really working on this since April, they all appear to meet those criteria. And so as we're moving through this work together, as I'm seeing recommendations from any advisory group, whether it's CCAC or this task force, if we're meeting those qualifications, then we need to be moving forward together to implement those thoughtful recommendations. And that will be, my working plan during my administration. I can't comment for the way things used to be. I can only comment on how they are since August 1st of last year. But I'm very serious about this. I'll be the first to say that after doing a deeper dive with DEI over these several months, that I'm not happy. I'm not happy where we are presently. We have work to do. And you need to know that we're willing to do it and to do it in good faith. But I am pleased that we're better today than we were a year ago. And we're much better today than we were in the middle of the pandemic. I'm not going to use the pandemic as an excuse, but I mean, y'all were serving in your fields during the pandemic. You know, it was not easy times for any of us. But thankfully, coming out of the pandemic, things are looking better across the board for us as we've been able to pivot from pandemic response at the health department, which was agency-wide, literally trying to get us through that as a population back towards our core programming and especially our provision of core public health needs at the local level. So recognizing that our low enrollment rates coming out of the pandemic were very real and that provider numbers were down significantly, one of the first orders that I gave a state health officer last year was to increase provider rates. And we had accumulated some resources and early intervention through the pandemic. And we had enough money on hand that we could increase provider rates across the board and to give an incentive rate for those who would do services in natural environment of care for our children, and that we could sustain that for about a year. And I made sure that our friends at the legislature understood that those rates were unsustainable with our current level of maintenance of effort at the state level for funding of EI. And those of you who understand this program know that the feds require the state to provide maintenance of effort every year equal to or more than the previous year. We had been running about $1 million a year, which was woefully inadequate to take care of providers and run the program. But you know, after us increasing provider rates, we saw a significant increase in providers. We saw a significant increase in enrollments. We have already made up all the lost ground from the pandemic and are back to either pre-pandemic levels or almost there and growing. And I advocated during the legislative session last term through the appropriations process for early intervention to receive more state funding for maintenance of effort, and we received it. We received an extra we received $2 million for maintenance of effort to go straight to providers, which brings our current maintenance of effort to about 2.4 million, which is still too low, still way behind our contiguous states, but it's significantly better. And at least we can hold our ground where we are. It won't give us much of anything to do more than we're doing, but at least we can keep doing what we're doing, which is working. And I have confidence that that with y'all's good advocacy, we'll be able to encourage the legislature to improve that funding. I also believe and expect of my team that we're to have an attitude of customer service, and that's for all of our programs. That's for all of the services that we regulate. Look, I don't know how to do things based on state government. I just know how to do things from the private sector, and I'm bringing as much of what works in the real world to state government, not all of which will work, but customer service works wherever you are. And cultivating that attitude of customer service is extremely important to me. I take complaints very seriously, which is why you don't need a task force to work with Dan Edney. You know, I will pick up the phone whenever you call, and as I realize there are issues, you know, we will address those issues. But that is true for early intervention. And for us, you know, the customers for early intervention certainly include our children and their families, but they very much include our providers and our partners that are all represented across the call today. And I am challenging you, and Senator Boyd, Dr. Buttress, y'all included, if you have a problem with anything at the health department, you need to call me. Let's talk about it. And I'm committing to you. I have a year of experience doing this. I'm readily accessible and very transparent. I'm going to tell you what I can do. I'm going to tell you what I can't do. And when I can't do something, I'll explain why I can't do it. And then we'll look for another way to get to the same place. And I think most thoughtful individuals will agree that that's a good way to do business. But I expect you to receive customer service when you're interacting with anybody at the health department. I want to tell you that I apologize personally for anyone who has not received good customer service from anyone on my team. And it's unacceptable. And I'm actively intervening to correct some of the things that I've been hearing in terms of acting more like a state bureaucracy instead of as an appropriate partner. To demonstrate my sincerity, one of the recommendations that I thought was really appropriate was to help eliminate the frustrations with billing for our providers and our families. Now, I think y'all know that based on the federal regulations, we must be the payor of last resort. That means we have to demonstrate to our federal partners that we have attempted every way possible to get resource payments from private insurance and or Medicaid before we use federal grant money to pay providers. And I know that's frustrating. As a private clinician for over 30 years, just becoming a Medicaid provider is not easy. And then oftentimes dealing with the Medicaid system is not easy, nor is dealing with Blue Cross or anybody else easy. And I absolutely get it. So one of the recommendations was to look at a pay and chase model for reimbursement, which I think has a lot of value to it if we can make the economics work. And that would be where we would guarantee, we do guarantee payment to our providers. But if we have the system in place where I can demonstrate to our federal partners that we are using federal grant money as a last resort, then we can advance payment quickly to our providers, and then we can bear the responsibility of dealing with things like prior authorization, which shouldn't even exist in early intervention, but it does with Medicaid, and deal with the burden of chasing down payments, and then really just free up our providers to do what they do best, and that's to take care of our children. I am very willing to move towards that model. There are some financial constraints based on our low level of funding to make that happen. But Dr. Buttress, I do think that we can do that, and that will help expedite initiation of services and take a large burden off our providers. So as we work together, we have to look at the things that the health department can do better, the things that appropriations at the legislature can do better, things that our providers can do better, things that our academic partners can do better. And look, I've practiced medicine in Mississippi long enough to know we can all do better, but I'm declaring to y'all that the health department is going to do better. I'm proud that we have done better these last several months, but that's just gotten us back to square one, and we need to move on down the road for the sake of our children and families. So I appreciate your help. I appreciate the advice that you give. I appreciate your service on our advisory panels and certainly this task force, which you're taking out of your private personal time. And I stand ready to help work with y'all every way that I can. So Dr. Buttress, thank you for this opportunity.
Dr. Edney, thank you so much again. And you and I talked earlier, and I know you from the past, and I know the job that you've done in every avenue that you have been in, and I know that you're sincere. So we really appreciate those words. If you don't mind, since I know you are time limited, would you mind answering any questions from the task force or our advisors in the next few minutes, please?
Yes, anything that I can, and if I don't know the answer, I will sure get it for you.
So the floor is open. If you will, if you're online, if you are an advisor or part of the task force, feel free to, you can raise your hand or unmute and speak, and then remute when you finish your question, or if there's anyone at the table. So. I'm not seeing any questions. Am I missing anyone? Well, thank you, Dr. Edney. We really appreciate you, and I hope you can stay on and listen for a bit, but when you need to leave, we understand.
Great. Thank you so very much.
All right. Well, we'll go to our next person giving testimony. And before I start that, let me just remind you you're limited to 10 minutes. And what we'd like to do is go ahead and save the questions for the next several until the very end, so we can make sure that everyone gets their adequate time. So with that, Ms. Biz Harris is next. Biz, if you want to tell people a bit about who you are and then your testimony.
Thank you, Dr. Buttress. Good morning, everybody. I am Biz Harris, the Executive Director of the Mississippi Early Learning Alliance, or MELA. MELA is about a 4-year-old nonprofit that is dedicated to building and supporting coalitions for babies and toddlers and preschoolers in Mississippi around their early education and development. So we have, and so we really think of ourselves as grassroots advocates collecting the voices of families, child care providers, early educators, and other early learning and early childhood development advocates. So what I am not an expert in early childhood development. I am the mother of a 5-year-old and a 9-year-old. So I am, right out of the sort of very early baby and toddler stages, and my heart is with the littlest ones of our state. That is my deepest passion. But again, I am not an expert. What I am, though, is someone who believes very strongly in making sure that all policies that we develop at every level of the state focuses on listening to grassroots voices of members of our community. So what I want to share with you today are some themes from some interviews that I conducted actually as a subcontractor for Start Early and the State Early Childhood Advisory Council in 2022. My team interviewed, we interviewed a lot of people, but I personally interviewed about 30 parents, 6 or 7 of whom had experience with early intervention. So I had children who had gotten early intervention services in Mississippi between the ages of 1 and 4. So it's a very small subset of the findings I wanted to share with you today, but I think it's really interesting because there were really concrete themes that came through. You have the themes on a sheet of paper if you're in the room, and virtually in the email that Mary Claire thankfully sent out for me, but I also have them up here. So I mentioned that we had a lot of people that we talked to. Only a few had experience with First Steps to Early Intervention Services, but they were from all over the state, and they had they were from many walks of life and demographics. So it wasn't just one subset of people that we talked to. Okay, so before I share the themes, I want to share one particular story with you because I think it really encapsulates all 6 of the themes. There was a parent that I spoke to who had a child who at 6 months realized that her child was not holding her head up or moving as she should. She had older children, so she was aware of children's developmental stages and felt like something wasn't right. When she spoke to her pediatrician about it at the 6-month well check, the pediatrician said, I think it's fine, and brushed her. It felt her words were brushed me off, told me that it was going to be fine. At the 9-month well check, the same issues were happening, and the child had still not met the developmental milestones. So the mother was very concerned and said, I think it's time to do something. And again, she said the pediatrician brushed her off. At 12 months, there was a new pediatrician that she saw who said, I think it's time for you to see a neurologist in Jackson. They got the appointment as quickly as they could. And the family was in the Pine Belt, I should say. They got the appointment as quickly as they could. They went to see the neurologist, and after a barrage of testing, an MRI showed that there had been a loss of oxygen to the brain somewhere around birth, around the time of birth. So it was a pretty severe issue. The child immediately started occupational therapy, physical therapy, and speech therapy at between 1 and 3 months, I think. Somewhere along the line, the family was paying out of pocket because their insurance would not cover those services. So they were paying a great deal of money, and finally asked a therapist, can you help us? We don't know what to do, but this is really, we have to do what we have to do for our children, but we really cannot continue this. And they learned through the therapist about I believe it's called the Disabled Child Living at Home program through Medicaid. So they were able to get some support, which was really helpful to them. Somewhere along those lines, the parent went to have her hair styled, which I think this is sort of an important point here. And the stylist, in talking about the child, mentioned that there was the Children's Center at USM, and that the child might be a candidate for services. They are wonderful, which we're going to hear more about today. And the child began services there, and it was driven by her grandparents because both parents worked full time, and the child didn't live in Hattiesburg. It was driven by grandparents and babysitters and carpools, all back and forth to this really wonderful place where the child was flourishing. I think at that point, the mother said, I am incredibly thankful for these services. My child has a happy ending. And at the time when I spoke to her, she said she is a normal 5-year-old, but we were told that if she hadn't gotten these services when she did, as early as she did, and if she had gotten them sooner, how much better would it have been? But when she got them, now she is a normal 5-year-old, and we were told she would be in a wheelchair and maybe wouldn't be speaking. So, but now she's a normal, 5-year-old. So I think that leads me to the themes. I love that the story has a happy ending, and I think that's important because every person that I talked to who had gotten services through an early intervention support, sung the praises of the fact that their child was in the exact place they should be because of those services. By getting the services early and when, as soon as possible, their child has a happy ending. Their children are where they need to be developmentally. So I think that's really important to note here. The next theme, I think, though, is that caregivers reported, and that the woman in my story about the pediatrician sort of continuing to say, let's wait. That was in most of the stories, that was actually people's experience. Oh yeah, we'll talk about it down the line. One parent shared with me that they went and were evaluated by the hospital's speech therapy services, only to be told that we really don't want to serve your child until they're older than 1-year-old, or way down the line. So, and then in some cases, there were pediatricians that were aware of what was happening or what could be done, but that was about as far. There is a first steps program, and that was all the pediatricians really could say. So I think there is a wide variance of pediatricians and health caregivers' awareness of what's happening and what can be done before a 1-year-old. I think the third, my third theme was that first steps in particular, there was a wide variance of communication from the program. Some people were reached out to immediately, started services right then. It was amazing. Others, felt like they had to, advocate, make many phone calls to get someone to call them back. So I think that is something worth noting, that based on where they were in the state or who their contact was, things were very, there was a great deal of variance. The fourth theme is that caregivers, especially caregivers who worked full-time, really struggled to get to navigate the transportation to services. One woman I spoke to talked about not wanting her child to, not wanting or maybe the daycare or the childcare did not want a lot of people coming in and out. And so she had to leave work, pick her child up and take her child to the therapy services, bring her back. So that, I think that she mentioned, I think this is the person who said, it just didn't seem like they dealt with a lot of working parents. They didn't, and another one said, I had a flexible schedule, but we could not have seen anyone outside of the workday. So I think that's important to note, the scheduling. The fifth one, which I mentioned about the hairstylist, that there were various people and word of mouth opportunities for people to hear about the different services that existed. Some happened to have friends that were speech pathologists. Other did hear from their pediatricians. Some heard from childcare providers or childcare teachers whose parents were speech pathologists. So there was a lot of variance in how people heard about these things, which is how the system should work, right? Like we want as many people to know about these as possible. But there was sort of an element of, if you happen to ask the right person, then you heard about it versus this is how it goes for everybody. And then lastly, caregivers were often really confused about how to get help. This one person mentioned, I didn't know until I asked, and I, kept asking and kept asking and kept asking. And someone else mentioned that she felt like it was happenstance that she heard about any of the services at all. So really that feeling of being worried and concerned and not sure where to go to find the help that you need. I made this sort of confusing map because this shows all the different ways that the people I spoke to, like what process, how they got to the services and how they got to, their child getting what they needed. And I think that this map encapsulates the thing that I would like this task force to consider, is that we want our children to get services as quickly as possible because we know they make a difference. I also know personally from my work, there's some really amazing early intervention programs and early intervention providers in Mississippi that are doing incredible things. And so we are not program poor. We are program rich, but I believe that we are system poor in that there's so many opportunities where children may fall through the cracks. So I just really hope that we can really make sure that we can work out the system so that we catch the children before they fall through the cracks.
Thank you, Viz. Okay, our next presenter is Dr. Denise Powell, who's a member of the task force. Denise?
Hi, are you able to hear me?
Yes, thank you.
Okay, great. Awesome. Hi, it's lovely to be here. I'm really glad for the last session as well. I was writing down notes and learned a lot, so I appreciate that. I'm going to talk very quickly. Really, my main goal is just calling for proactive equitability and outreach to those who need it most. Just for background, I'm now 1 year out of residency and returning back to my home state of Mississippi, and I've really loved working here and have also continuing to learn about early intervention services, and it's something that we use. I like to use it daily just because the earlier the better, agreed with the last session. I was looking into the history of early intervention, saw that in 1986, the federal government really set those requirements for developmental delay services. But one thing that has also been noticed since the inception of early intervention is the fact that as much of healthcare and medicine, there are inequities that are also seen in early intervention services. So as someone very passionate about combating health disparities, just want to call that we keep in the back of our mind and at the forefront of our mind that there are disparities within early intervention services, even though we've made a lot of headway and a lot of improvement within these services. When we think about disparities, a lot of times, especially in the community that I work in, I think about socioeconomic status, how that can impact early intervention services. Within the last session that we just heard, we talked about transportation. So definitely thinking about that. I have a couple of families where they don't speak English as their first language. And I think sometimes as providers, we don't think about that and how it can impact development. A lot of times we say, oh, they're going to catch up and it's going to be fine. But we don't think about like what happens if they don't catch up. And then how are the families going to access these services if they're not able to reach someone with the same language or someone who's willing to get a translator on the phone. So making sure that we're being equitable with that. And then even families that are maybe deaf or non-hearing and maybe don't have translators that can help with that too. I've had a couple of families that have experienced troubles with that as well. So translator services, I would say, are really important. And then also thinking about our just children of color and the history within this nation and how that impacts care even today too. So thinking about that as well. So my main thing was really just making sure that when we're revamping or really continuing to improve, which I've seen we're already doing, that we're also thinking about equitability, resources, and reaching out to the communities that need it most.
Thank you, Dr. Powell. We appreciate you down on the coast. Our next presenter is Dr. Ju1y Parker. Dr. Parker.
Good morning. Thank you, Dr. Buttress. I appreciate the opportunity to once again share some information with the experts here in this task force and then others as well too. I've had several opportunities both last fall with the Senate hearings and a couple of opportunities on both of the advisory boards that I sit on, the SICC, which is the advisory board for our Part C program, and then CCAC as well too, to really discuss early intervention in our state and the importance of the program, our Part C program in our state. And so I'm not going to kind of revisit many of the things that I've discussed in the past, but there is one very specific topic that I would like just to share more information about this morning. I think both from Dr. Powell and Dr. Edney's presentations, there are components to what I feel like are important for our Part C system that really fit what they're discussing. So I'm in part of my request at the Senate hearings last fall, I noted the importance of expanding services or expanding eligibility for child development prepared individuals to work within the context of Part C. Luckily, the Senate bill that was authored by senators on that task force was actually approved and is now a part of law. And so we're very excited about that opportunity. However, I think there's some level of uncertainty throughout our state in regard to what that really means. And there is certainly some level of uncertainty about the qualifications of those individuals who hold that undergraduate degree in child development. And that's mainly what I want to address just very briefly this morning, because I do think that that's an important component to what Dr. Edney said. One, for making sure that the recommendations that are made are not self-serving in any way. And so I do want to preface my information here with, yes, I am a associate professor at Mississippi State University, and I do have both a master's program in early intervention. That is the only master's program in early intervention in the state, which I'm very proud that Mississippi State houses that program. And then also we have an undergraduate program in child development. And then also to Dr. Powell's comments about equity, which is really significant within the context of our state. We have institutions throughout our whole state who actually prepare undergraduate students in a child development or child and family program that are in areas of our state that desperately need more very well-trained service providers. And so that was the issue, that was the rationale behind the proposal to include child development trained individuals for that special instructor role. And so I think I'm getting some feedback. I'm not sure if you guys all hear that or not, but what I wanted to share was just some additional information about how this is not a recommendation that is just specific to Mississippi, that about, well, there are many other states in the nation, but I can share with you at least 8 other states in the nation. I'm going to share my screen for just a moment and show, well, I think I'm going to share my screen if it's going to let me. We'll see. Let's see. I was making me go to settings. Let me see if I can get this work out. If I can't, doesn't look like I'm going to be able to share, and I apologize for not sending this document in prior to our meeting this morning, but what I did pull together was about 8 additional states, and those are just a few states, Alabama, Tennessee, Georgia, South Carolina, and then some states kind of outside of our southeastern region, Maine, and trying to remember the other one. But so for about 8 states that specifically have within the description of their either special instructor, or some states call them developmental therapists, it specifically identifies well-trained professionals with a background in child development, early childhood, family studies, and then it goes on from there. So it can be very diverse, because Part C is a discretionary program. The federal government does allow states to actually set that criteria for their state. And that's why it looks differently, or can look differently, throughout our nation. But Mississippi will not be the only state that widens that eligibility opportunity to bring in very well-trained professionals to work with very young children and their families, specifically because we recognize that having a background in child development, understanding the trajectory of development, understanding a family-centered kind of model of service is what our child development prepared professionals pre-service are being prepared to do. And early intervention is just one of the settings that they can actually use their skills very well. So from that perspective, I just wanted to say, and I apologize again that I can't share my screen, but I will send this to Mary Claire, and she can certainly distribute it to the task force. And what the document says is it gives the title of the job description, the title of the profession within the state, the job description, and then also the requirements for degree preparation. And then also it also identifies if it is a full-time benefits eligible position as well too, which I think is important. And I think that there will be some additional testimony this morning to address that. Also, I'll note that as of last Friday at the last SICC meeting, there was an opportunity to share some additional requests. And so Dr. Coatney and I will be working toward that request to really help develop a description for what that inclusion of child development prepared personnel should look like. And so I'll be happy to share that in coming meetings once the SICC has actually approved that and our early intervention Part C program moves forward with that. But it's very important to our state to look at workforce opportunities and recognizing, as I've noted in several other meetings, that our neighboring states have siphoned off our child development prepared professionals many, many years. And so it's time for Mississippi to use the brain power that we're generating throughout our state at many different institutions of higher learning and let them stay in their communities and serve the families in their communities. And so I appreciate the opportunity to share that again this morning.
Thank you, Dr. Parker. And yes, if you will send that presentation, we'll make sure that we send it out to the entire task force.
Thank you.
Okay. Our next presenter is Dr. Katie Cassidy, who's an advisor to the task force. Dr. Cassidy?
Good morning, everybody. My name is Katie Cassidy, and I'm an occupational therapist. I have two roles. I'm a full-time faculty member at UMMC's Department of Occupational Therapy. And as part of my position there, I spend 8 hours a week in practice of occupational therapy. So during those 8 hours, is it on? You all hear me okay? So during those 8 hours, I serve as a contract provider of occupational therapy with our First Up program here at Mississippi. I see kids in the Jackson area, and I've been doing that since September, so I am a new provider. And I see babies in their homes or in their child care centers. So I would like to take a few moments just to tell you how I found myself in these positions. About 10 years ago, my husband and I adopted our daughter who has some significant special needs. And I found myself as a full-time working mom with two kids who are both 2. One of them who needed many hours of therapy a week. So I spent my lunch hours and time off of work driving her to different therapies and to different schools, trying to get just the best care for her while I also tried my best to excel at my career. I eventually could not keep all of that together, keep all of that going, and I had to make the tough decision to step down from my position and have more time for my daughter. Because of her specific needs, I was learning so much about occupational therapy anyway that a few years later, I decided to go back to school and become an occupational therapist. So my passion from the moment I started OT school was that I eventually wanted to work in some capacity that made therapy easy for families. I had been through that struggle, and I wanted to support the families who did not have the option like I did to leave my job and have more time to get her where she needed, and frankly to those families that shouldn't have to leave their jobs to get the services that their child needs. Early intervention was the perfect fit for me. I had that desire to support the entire family. So this is one of the few areas of occupational therapy that the client is the family, not just the child. So it was a perfect fit for me. And because it takes place in the child's natural environment, it allows families to maintain their routines. It allows families to access therapy without completely shifting their schedules and their lives. And because we serve children 0 to 3, I get to become part of that family support system right from the beginning, as early as possible. So I wanted to tell the task force about my background just to highlight what I think, in my opinion, are a few big picture ideas to keep in mind as you explore changes and discuss changes in the current system. Therapy is exponentially more effective in the child's natural environment. And I know that we often hear this, usually in terms of the child. So the child being more comfortable, you get a better evaluation, an idea of that typical level of development when the child is in their natural environment. And that's absolutely true and very helpful for therapy and evaluations. But I wanted to emphasize just the need for us as an EI program and providers just to lessen that tremendous burden on parents. And having a provider who steps into the family's routines and lets the family guide therapy is critical. One of my mentors always suggests starting out with the family to ask, what is the one thing that keeps you up at night, concerned about your child? And we start there. So taking away the barriers that those families experience when therapy is not in that environment allows us to really help the family and the child in the way that they need most. I'd also like to, just another big picture, highlight the impact that therapy in the natural environment has on the community in addition to just the family and children. So I see several children at their child care facilities and their caregivers are a wealth of information. Often they are the ones who suggest referral or notice delays in development and talk through that with the parents. I've talked to several who have actually helped the parents walk through the program, getting started with the program. And when I work with the children at those centers, I form relationships with the caregivers, and I'm able to educate them on ways to facilitate development for the children. Many times that education carries over to other children at the facilities. I know we've heard several people talk about back to the testimonies in the fall as well for the Senate about how we need to just be seeing more kids in our state, and especially in our area. And so I definitely see that on the day-to-day in my practice, that just so many kids are in need of these services. And so that connection that I'm able to form with those relationships at the childcare centers only happens when I join in those daily routines with the child. It has such a big impact because the caregiver can actually continue therapy when I'm not there, so that that child is really getting the services throughout the week. I don't know much about the University Hub model that's in the bill to be explored. I look forward to learning more how that operates. I would want to know how the model would promote supporting families in their routines, like I've been talking about. And Dr. Edney mentioned First Ups has recently increased pay for services, paying a higher rate when therapy happens in the home or in the daycare based to traditional clinic therapy. And from a therapist perspective, I think the new model would have to continue to incentivize that kind of treatment versus a traditional clinic job. And so that the therapist has that incentive to provide services in the home and community supporting families. I would also want to know about how much flexibility salaried therapists might have to accommodate needs of the families. Just thinking through what I do now as part of my services. One of my biggest strengths as being a contract therapist is that I set my own schedule. So this happens to me almost on a daily basis. If a baby is asleep, if they're at medical appointments, I'm able to easily switch the times and days that I see them. And so that again goes back to really my start in the very beginning, is really making this therapy happen as easy as it can on the family's routine. I've experienced some, just the current First Ups program as both a parent and a provider. And as a parent, I experienced some issues that I think are somewhat common. Like has already been said, when my child qualified for special instruction services under the program, but we didn't have a provider at that time in my area. And as a provider, I've struggled with communication and had to be really proactive in seeking information. Just for instance, I try to find out when the SICC meetings are held and attend those when I can, because they provide good updates on the program. Most therapists are not able to attend those meetings because they're seeing patients, seeing the kids. And so lots of that information is not always known by most providers. And I've reached out to other community members trying to learn more about how the program works. Just done my own searching for updates. That's how I found the Senate testimony regarding this bill that we're here about today. So, and those are just my big picture takeaways. I hope the information is helpful, and I'm happy to provide more research, more information to the task force.
Thank you so much, Dr. Cassidy. Okay, our next presenter is Ms. Sarah Myers, who's an advisor to this task force.
Good morning. Thank you all. As Dr. Buttress shared, I'm honored to be here. I'm representing the University of Southern Mississippi, and specifically in my capacity as the director of the Children's Center for Communication Development. It is a university-based program, so we're going to speak a little bit today. What I'd like to share with you is some Problems that I've currently observed in the EI program, not as necessarily a staff member with Department of Health, but of course as a director and a speech language pathologist treating in early intervention for many years. Additionally, I feel it's important to note that I serve as the Public Awareness Committee Chair on the SICC, as you heard others mention, the council to support early intervention in the state. So I've gleaned some additional information through that and found that very helpful, as Dr. Cassidy shared, in understanding what providers, early intervention providers currently doing this work are experiencing across the state. So first, let's just jump in. I'd like to walk you through the referral process from referral to admittance into early intervention, and currently what that looks like and what some of those issues are that we know are happening through that process, okay? So while anyone can make a referral, if you have concerns that a baby has delays, you can make a referral to the State Department within 7 days. But typically, and what the majority of the referrals are happening and what we're hoping would happen are coming from physicians. So they should come from the medical hubs, because those are the folks who see these families on a regular basis and understand their medical condition and or experiences, right? So we're going to talk through that process. So the first problem that you can see is that there's really very minimal incentive for a physician currently to refer to the state. And what I mean by that is if they make a referral to the State Department, they very minimally, rarely get consistent communication from the State Department around those early intervention services. I've spoken to several pediatricians in my region and other regions around this problem. And so that directly does not reinforce them to do it again, right? The other issue is that regardless of if they make a referral to the State Department or they refer directly to an outpatient pediatric clinic to get one of those therapy services the child needs, they're going to get outpatient therapy services regardless, because there's a lack of providers providing this least restrictive environment, natural setting service provision. And as we talk through this, you'll kind of probably form your own conclusions about some of these issues, but that's one of the first issues that I think we need to address, is that these medical homes are not making the referrals consistently. So we're not even catching all the numbers of children that need these services. As you heard from a testimony earlier from Ms. Harris as well, this happens frequently, unfortunately. So the second step in the process is that the referral from the physician will go to the state, and then it will travel to the local health department, where it will be assigned to a service coordinator. The service coordinator then will call the family and schedule a time to come to their home and do an intake. Now, this depends heavily on that service coordinator's availability, capacity to go drive to that home and provide that intake. That intake takes about an hour. It's pretty lengthy, it's pretty in-depth. And some parents have reported that feel a bit uncomfortable with it, could be a bit invasive. Because it's the first time they're meeting these people, right? And they have a baby and you're in their home. It's a very sensitive time. So unfortunately, that is some folks' perception, not all, but there we are. So we have a delay. And it depends heavily on that service coordinator and that family to be able to coordinate that first visit, okay? The intake occurs in person, as I stated, and that's essentially just gathering information. Then the service coordinator is tasked to locate 2 early intervention providers in 2 different disciplines. As you can imagine, all across our state, it varies widely, right? Who's available and what the child's specific needs may be. I will say, as Dr. Edney shared earlier, one of the great things that they have done is they've raised those rates, as you've heard mentioned. And so a lot of folks, providers that I know, are raising their hands and saying, I would like to be an independent contractor for early intervention. I would like to assess and evaluate children. That's a really good reimbursement rate because it's a contract position. It depends on your schedule. You can schedule it when you want. It's very flexible. So hopefully we're moving in a better direction there. But again, that is going to depend on the availability of the providers. So the service coordinator has very little agency to move things forward if they don't have providers to do the assessment, right? Number 5, okay, we talked about that one. So we get to the evaluation. The evaluation occurs in the home, as it should, ideally. Sometimes it will occur in other settings, like a clinic or outpatient setting. And then those evaluators leave, they write up their recommendations in a report, send it to the service coordinator. And now the service coordinator is not done They need to go back to the home to do an interview with the family. This is what we call the routines-based interview. So this is essentially understanding what the family's day-to-day is and how we can create goals around that daily routine, okay? Again, if you'll remember, we're at what, step 8, and the referral happened from the physician many steps ago, and they still typically haven't heard anything from the early intervention program. So we're all the way to step 8. We've got our routines established, our goals written. Now the service coordinator is tasked with the harder job of finding providers to serve the child. Oftentimes what I'm hearing and what's unfortunate from families, from providers, and from our folks, our friends that are service coordinators trying to do this work, they've got between 50 to 80 children on their caseload. And they're serving in some dry counties, maybe some regions that have very limited access to service providers that can provide these services. And oftentimes, the physician may have already known that the child needed, let's say, physical therapy. The evaluation determined the child needed physical therapy, but the system doesn't have a physical therapist in that region. And so the service coordinator is stuck between a rock and a hard place, trying to make a recommendation. And usually, unfortunately, what could happen is the family goes through this entire lengthy process and there's nothing to offer. So they have to then say, go to an outpatient clinic, pay copay, pay out of pocket. Maybe we'll be able to reimburse some of that, you know, but unfortunately we don't have a physical therapist to provide the services. One of the issues that I've come across in my role as SICC, Public Awareness Committee Chair, we conducted a survey, just an informal survey that yielded about 260 early intervention provider responses across the state, and it was a good variability of folks that are practicing under 5 years and folks that have been practicing for decades in the state, right? Overwhelmingly, those are independent contractors, and overwhelmingly, some of the issues that they brought up is that they have raised their hand, they have enrolled in the process. It is a lengthy process to get access to the MIDI database, which is the early intervention database. It takes about 3 different training sessions. Some of my providers, it has taken 6 to 8 months before they could get in the database to start treating and putting their notes in. I think that's important to note. That's something we can easily fix, I think. But they've raised their hand and they said they're ready to serve in their area, but there's no live system for these service coordinators to know where these providers are and how to access them. So we don't know these folks are out there. They're enrolling in great numbers because, again, those provider rates are pretty good, those reimbursement rates. The state's done a good job there, but there's no house for them to live in. And so I've had folks that have enrolled, have been providers, and have gotten 0 referrals for several months. And they've been in areas that there were absolutely children that needed those services. So I think we got to the end here, but essentially you understand most of the problems, most of the themes. If the provider is confirmed, the last step, 10, we find some folks that can do these services. One of the things that service coordinators are sharing that are issues is that the providers then have their own state policies before they can treat children. And so then they're holding up the system in that they have to reach back out to that medical home and get information, right, to be able to treat. So there still can be delays even after that. Okay, I think we spoke to those 5 main issues. Overall, you can see overwhelmingly there's frustration on all parties. There's not a lot of collaboration and communication happening. And families and medical providers, they don't really understand the process at all. And they don't understand where they are in the process. So you can see why we're hitting roadblocks throughout this process, okay? Let's go to the next slide, please. Oh, I can do that. Okay. Because of my role here to represent University of Southern Mississippi and my role as the director of the Children's Center, I'll explain that program. It is a university-based program, and I hope to use some pieces of this as a framework or a model to give suggestions to the task force and the legislators for possible supports to help change and rework the system. So we are housed out of the university's 2 campuses. We serve that greater kind of southern region of the state. We serve children, our priorities are children at the youngest age with the highest intensity of need. So unfortunately, we do have a wait list, but we constantly are, and I'll talk through that, reviewing as a team and sending those referrals back out to other agencies like, of course, the state agency. To make sure that any child that's referred to us and does not fit one of our priorities for enrollment is getting services somewhere. We don't ever want a child to be waiting for services. Because we're on a university campus, we also are training pre-professionals. I think it's wise, and I commend our legislators and Madam Chairman Boyd for ensuring that our universities are represented here, because I think they need to understand that these pre-professionals that they're preparing to do this work, we need them, and we need them in early intervention. And so they need to know some of these critical pieces of what best practice looks like and how they can play a role here to make a real tremendous difference. Because again, overwhelmingly, those providers that answered the survey, even though they're incredibly frustrated with lack of communication, consistency, and resources, they want to do this work. They're very passionate about this work, and they want to do it because they love working with infants and toddlers, and they love establishing these relationships with families. So with the Children's Center, it's a much shorter process. The key is we employ full-time therapists and providers at the university. So they are not contract. They work with us, okay? So then, as you can imagine, what happens is if a baby is sick, as they often are, if someone is sleeping and we can't provide the intervention at that time, these folks don't lose pay, right? They're still employed and they still have other things that they can be doing. We're doing clinical rounding on these children on a regular basis as an interdisciplinary team. And we're using the primary service provider model for children, or the transdisciplinary model often. Essentially what that means is that, sorry, little lengthy. Essentially what that means in a nutshell is that one primary provider, like a speech pathologist, is going in and providing these services while consulting with the other disciplines to ensure that those things are happening. So as you can see, it just cuts wait time significantly. So I'm going to skip right ahead, if that's okay, Dr. Buttress, this part, the last slide. Okay, so here's the proposal. Again, not an expert in the early intervention program, but wanted to provide a framework, a possible model for the task force to consider. So I would, and my team would highly suggest employing providers with the State Department. These folks could work at the health departments, and they could be there to collaborate and share some of the load with those service coordinators to make sure that when a referral comes in, they can quickly determine what the needs are and what their availability is, even to assess and treat from the beginning. And the intake can happen through telehealth, through phone calls. All that stuff can be reduced to minimal visits for the family, minimal burden for the family. So essentially, in a nutshell, that's the recommendation. I appreciate your time.
Thank you so much. Again, there'll be questions afterwards, or if you want to clarify any points or ask any questions from the task force or advisory committee. Okay, our next presenter is Ms. Miranda Carter, who is a member.
Hi, you all. Good morning. My name is Miranda Carter, and I'm a former elementary educator, and I'm currently a stay-at-home mom to support my 4-year-old son. I serve my community as the vice chair of Excel by 5 for children ages birth to 5 in the Petal School District. It's a volunteer-based program promoting school readiness in our state. And I also serve as a community outreach for our local Cosmopolitan Club and my church. And lastly, I started the Key Family Resource, a group created for families of disabled children to share resources and walk us alongside one another. Serving my community, even as a stay-at-home mom, is very important to me and a passion I hope to share with my son. First, I'd like to say it's an honor to have the opportunity to serve our state alongside you all in the Early Intervention Task Force for a cause so dear to my heart. I have no experience in public speaking, and honestly, just talking to you today terrifies me, but I wanted to address you because I'm so passionate about the children in our state, their overall health and literacy. I wanted to first take a moment to share my personal experience with our First Steps program. And I'm sorry to say it's a very personal experience, and it wasn't initially a positive one, although it did end on a positive note. When my son Hudson, this is Hudson right here, he is 4 years old. When Hudson turned 12 months, we noticed some things had changed. He quit speaking, babbling, or making any noises, and he wasn't reaching his milestones. I took him to, sorry, this is so emotional. I'm sorry, y'all. I took him to his pediatrician and his parents, his teacher, instructor. Both made a referral to our First Steps program. I was so relieved and hopeful because as a first-time parent, I knew something was wrong. But I didn't know what specifically. Additionally, that day, our local pediatrician made a referral to Oshner's to a developmental pediatrician. We were told the wait for a developmental pediatrician was approximately 18 months to 2 years. I felt so defeated. I called and spoke with a nurse who told me the process. We would wait at least 18 months to see the pediatrician, and she would order a variety of tests, and I knew I had to find another way. So I requested our local pediatrician to go ahead and order the test so I would have all the results present for the developmental pediatrician on our first visit. Our second appointment for those tests was genetics. The geneticists could see the challenges we were facing without even running their first test, and Hudson had an appointment. He had an appointment with a developmental pediatrician the following month, so we avoided that whole 2-year wait. I say this to say it was very obvious to these pediatric specialists that Hudson needed help. But when we went to our First Steps evaluation, just 2 weeks later, we were told that Hudson was, and I quote, cute, and I quote, everything would be fine. No referrals were made for speech, occupational, or physical therapy. Sadly, I heard this was the case with 2 other families who were also told in the same office that their children were cute, but their obvious developmental delays were not addressed. Further, a year later, after requesting a copy of our entire file, I discovered that the First Steps coordinator had documented home visits that never occurred. Sadly, that wasn't even the worst of our personal experience. We were threatened, bullied, gaslighted, and yelled at by our regional director as we tried to obtain services. We were also told from a First Steps regional director that she makes the decisions who receive services, not physicians, even though we had an order of medical necessity and many therapists stating our son required therapeutic services. Honestly, as I look back over the whole experience, it brings a lot of anxiety, and I still don't understand why we had to fight so hard. But from this experience, we have been able to walk alongside several families who have had similar experiences in our state. For one family to have our experience is too many. However, I have met several just in my area, which is the Pine Belt. The difference in myself and those mothers was that I was blessed and able to stay home and advocate for my son as needed. I had family to help watch my son while I advocated for him. And I had one child who required my attention. Unfortunately, the mothers I met along my journey had to give up their fight because they could not advocate and juggle the responsibilities of their jobs and their role as a mother to multiple children. Countless research shows the importance of early intervention. However, children in our state are being denied needed services, or their parents are unaware that help exists or how to receive it. Additionally, I would like to explore ways our state can provide therapy in the natural environment, and I'm speaking of particularly speech, occupational, and physical therapy. It is proven to be more effective, and I feel like it is a necessity for families who have neurodiverse children. And if you're not familiar with that term, neurodiverse means autistic or children who are ADHD or have sensory processing disorder, along with others. And I would also like to propose that we bring someone on board for consulting purposes who is independent from our state. And one person that I would like to propose is Carrie Ebert. She's an international speech therapist and early intervention specialist. She resides in Kansas City, Missouri. She's the mother to an 18-year-old autistic son, is an advocate for neurodiversity affirming practices. And I would like to see our state consult an expert in this field to ensure our neurodiverse children ages birth to 3 are receiving adequate support. And I plead with you as members and advisors to make every decision in this committee as if you're advocating for your own children and grandchildren. I don't have any further solutions to propose, but I pray that as a task force collectively, we can find solutions for families encountering similar challenges with our state's First Steps program. I've gathered a compilation of voices from the Pine Belt, including providers, parents, and former First Steps employees, and I look forward to submitting and sharing those testimonies with you all. Thank you for your time and the attention that you gave me while I shared something so personal to my family. And I also want to take just a moment to thank Sarah Myers, who is the director of the Children's Center for Communication and Development, Leslie Junkin, who is the director of MSPTI, and also our guest speaker today, Alicia Westbrook. As all 3 of these ladies have supported our family and have helped us to have services for Hudson. They've helped us with supportive resources that have helped us to support him and support his development. And I'm very thankful for them and for their programs. So I look forward to continuing to work with you all to create positive change in our state. Thank you.
Thank you so much, Ms. Carter. That was, I know that was difficult for you. Thank you so much. It was good information. Okay, we have next on the agenda, Dr. Barbara Saunders, who's Division Chief of the Child Development and Behavioral Pediatrics at the University of Mississippi Medical Center, was going to testify as an expert. But she has laryngitis, so she sent a letter in, and Mary Claire will read it for us.
So I apologize if I mess this up. These are not my words. And if I stumble, I do apologize. We do appreciate Dr. Saunders for being so thoughtful and sharing this with us. To the members of the Early Intervention Task Force, I'd like to start by thanking each of you for taking the time to read my statement on early intervention services, and I sincerely apologize that I'm unable to be with you and personally deliver my testimony. Early intervention is a topic that is very important to me, both professionally and personally. Professionally, I am a developmental behavioral pediatrician. In order to become a developmental behavioral pediatrician, one must complete 4 years of medical school, a 3-year residency in pediatrics, and a 3-year fellowship in developmental behavioral pediatrics. Per healthychildren.org, developmental behavioral pediatricians evaluate, counsel, and provide treatment for children, adolescents, and their families with a wide range of developmental and behavioral difficulties, including learning disorders, attention deficit hyperactivity disorder, other disruptive behavior disorders, depression, anxiety disorders, tics and other habit disorders, regulatory disorders, including sleep disorders and feeding problems, autism spectrum disorder, intellectual disability, and others such as speech, language, fine motor, or gross motor developmental delays, and other behavioral and developmental problems. Developmental behavioral pediatricians work in multidisciplinary teams and frequently collaborate with educational and community services with the goal of optimizing outcomes and ensuring each child reaches his or her full developmental and behavioral potential. Personally, I am the mother of an almost 19-year-old son, Will, who has a rare genetic disorder, severe developmental delays, and special healthcare needs. Will was born at the beginning of my second year of medical school, so I have been navigating the world of early intervention services for about 18 years. As a medical student, I was just beginning to learn the importance of early intervention services, and over time, I've come to see that these services are vital to the children and families for whom I provide care. The literature is clear. Acting early on developmental and behavioral concerns is critical, as intervention is likely to be more effective when it's provided early in life. The first 3 years of life are a time of significant brain growth and development. During this time, babies' brains are the most adaptable, and intervening early increases a child's chance of reaching his or her full potential. Families also benefit from early intervention services as they are able to better meet their children's needs. Unfortunately, many children don't receive these vital services for reasons discussed below. As a new parent, I was initially unaware of early intervention services. It wasn't until my son was about 12 months old that I learned about the services for which he would qualify. My pediatrician didn't mention them to me or recommend them, and this is something I hear from the parents and caregivers of my patients as well. Many of them aren't aware that children could have been receiving developmental therapy services at no cost to them through the early intervention system. That's not to say that all families have this experience. I do see children who have been evaluated by early intervention and have received services when they come to K for evaluation. Some families report that their child was evaluated for early intervention services, but never received direct services due to the lack of funding and/or providers in their counties, a problem that increased during the height of the COVID-19 pandemic. Parents and caregivers whose children have received services report a range of responses related to the quality and quantity of the services their children have been provided. Some families report that their child's early intervention providers simply stopped coming without notice or follow-up. Other families inform me that their child's providers come regularly as per the IFSP, but that their child isn't receiving some services for which they qualify due to lack of funding and/or providers. Other families have nothing but positive things to relay about their child's early intervention services. They inform me that their child is receiving all the services they need, that their early intervention providers come as scheduled, and that they have easy and frequent communication with their early intervention team. I feel it's important to be frank and transparent about my professional and personal experiences with early intervention, as change can only happen if those in positions to affect such change know change needs to occur. In that vein, I hear more negative reports than positive reports related to early intervention services. The recurring theme amongst families who have negative reports is a lack of funding and/or providers. Another theme is inconsistent provision of services. I had a similar experience in Oklahoma when my son received early intervention services through their Sooner Start program. To turn the tide and increase the number of positive reports about early intervention services I and other physicians receive from the parents and caregivers of our patients will very likely require increased funding and personnel and providers. Pediatricians and other primary care providers should do their part by giving families information about early intervention services and referring children to early intervention as soon as a delay or developmental concern is identified. When we each do our part from the initial referral to ensuring adequate funds and providers are available to complete evaluations and provide direct services, to ensuring consistent service provision to qualifying children, then we will start to see optimized developmental outcomes in our children. Thank you for the role you play on the Early Intervention Task Force. The work you do is vital to the health and well-being of the children of our state. Sincerely, Barbara Saunders. Thank you, Dr. Saunders.
Yes, thank you, Dr. Saunders, for that. Okay, our last presenter, not least, is Dr. Alicia Westbrook, who's director of the Mississippi Early Childhood Inclusion Center. Dr. Westbrook.
Thank you, Dr. Boutros. Good morning. I'm Alicia Westbrook with the Mississippi Early Childhood Inclusion Center. And I just wanted to share with you a little infographic that we created to really highlight how MECSC interacts with early intervention in our state. So I also want to just quickly read my letter to the committee members of the Early Intervention Task Force. The Mississippi Early Childhood Inclusion Center, or MECSC, meets the needs of early childhood educators, families, and young children with disabilities by providing high-quality early childhood inclusion. Through a collaborative partnership with the Division of Early Childhood Care and Development at the Mississippi Department of Human Services, MECSC provides comprehensive professional development and on-site assistance to infant, toddler, and preschool teachers who are teaching in childcare. This supports help early educators better understand how to include children with disabilities and those at risk for delays in the early learning environment. Specifically, helping teachers engage children in learning activities and routines, supporting language and overall development, and peer interaction. In addition to our support for early educators, MECSC supports families through a variety of activities. Families who have concerns about the way their children learn, talk, move, or play, they contact MECSC for free developmental screening or autism-specific screenings. Through this process, we provide the developmental screening, and then we help families with next steps for diagnosis, evaluations, and services. Through our developmental screening program, MECSC always encourages families to talk with their medical provider, and we make appropriate referrals to both Part C and Part B. Sharing information about development and helping families through the referral allows MECSC to support Child Find, being available to meet families at early learning centers or at resource and referral centers across Mississippi. In addition to family requests for developmental screening, MECSC offers monthly developmental screening days at designated resource and referral centers in our state. Lastly, MECSC Resource and Referral, located in Hattiesburg and Gulfport, acts as a resource to families and service providers. Families of children with disabilities and with developmental delays utilize MECSC R&R centers for playtime with friends, our favorite, bi-monthly educational events, and to check out both adaptive and developmental learning materials from our lending library. Service providers often visit, utilizing the playrooms at MECSC R&R for family meetings, developmental assessments, and therapy. In addition to space, service providers across the Pine Belt access the lending library for developmental materials to share with families. The overarching goal of MECSC is to provide quality early childhood inclusion. Through our work, we are able to support children who receive services from Part C or Part B, and those who have not yet been identified. We strive to connect families, early educators, center directors, and service providers together, ensuring proper supports are in place so that children can learn, play, and grow in their learning environment. Thank you.
Thank you, Dr. Westbrook. Okay, now we have time. We've heard a lot, and we have time for questions, comments, thoughts from our task force members or advisors. So please, let's start the discussion. We have some work to do. We do plan to have some additional information our next meeting in August from the CCAC with the early intervention recommendations made there. And I'd love to hear also if anyone wants to add comment in August from the State Interagency Coordinating Council. So with that said, I'll open up the floor. If you have questions or comments, you can raise your hand or just unmute if you're online. Feel free.
I have a question, please. I know I spoke earlier about wanting to explore the possibility of offering therapeutic services such as speech, occupational, and physical therapy in the home because it is the least restrictive environment and proven to be more effective. Is there anywhere or any area in our state that is actually offering that through early intervention at this time?
There are some, yes, but we are, I can answer that in general. And Emily, I don't know if you have any further information. I haven't introduced, by the way, Mary Claire Ringer and Emily Cloy are with Peer and directed by Ted Booth, who are here with us, and I want to thank them for their incredible support. They are doing a great deal of research on what's going on with our early intervention, but also surrounding states on what's happening. And I will say, Miranda, that we are providing services in the state, in the natural environment. The unfortunate piece, though, our numbers are low. They're below the mean in the country. And yes, the data shows that early intervention services imparted in the home seem to be better serving our patients for many reasons. You mentioned some of them. The other point, I guess, is doing services in the natural environment takes more time. It takes travel. So if you're in a clinic, you can serve what? 8 patients a day. If you're out in the community going from place to place, you'll serve fewer, you'll use gas. And so I think that was why Dr. Edney moved toward the incentivization, which has been helpful from what we understand. But yes, that's one issue that we know. I don't know if you have any further comments, Emily.
Just that is federally mandated to perform therapy services in the natural environment, and providers would have to provide a reasonable excuse for not doing that. So just verifying what you said, there is a decent percentage of providers who are offering it in the natural environment, but we are below the mean nationally.
Thank you.
As a pediatrician, I'll make just a comment for knowledge. We have discovered over the years the fact that pediatricians many times do not refer to the early intervention system. And in fact, my efforts over the last 5 years have been concentrated in early childbirth to 5. And the majority of my work has been with the Child Health and Development Grant we call Mississippi RUG, that was HRSA funded, Health Resources and Administration funded. One of our big pieces of work was to do what we called enhancement of the pediatric medical home. And that was to improve developmental screening in pediatric offices, to be done with the periodicity scale that was recommended by Bright Futures, which is sort of our Bible for the pediatricians. The other piece was to enhance the referral process into early intervention services, part B and C services, both. So the birth to 3 is early intervention, and that's part C. And part B is 3 to 5. There's supposed to be a smooth transition. With that said, one discovery that we made when we talked to pediatricians in general was they quit referring to early intervention services because they found that their patients got quicker services if they my time. That they get more expedient services if they refer to a private provider because of the process that Dr. Myers outlined can take so very long. Then to find out that there is not a contracted service provider in the area, which becomes very, very frustrating. And then there was feedback that there was not communication back. This is not a defense for pediatricians. I will say that we have some fabulous pediatricians in our state. Many times the providers for the children are not pediatricians, but they're other medical providers. Family practice, who are wonderful docs too, nurse practitioners who can be a wonderful place. But the majority of our children in the state don't even have a medical home, meaning that they don't have a regular place that they go. So that's another issue. With that said, we know that medical providers need to do a better job. We know that access needs to be better. I think that Dr. Powell mentioned early, we need to make sure that there is equity across the board. Every child needs the same services. As Ms. Carter commented, thank you for that again, Ms. Carter. She was able to advocate for a child. There are a lot of parents who are trying to work with low-wage jobs and care for their family. So we've got to do a better job. It shouldn't have to take calling in Dr. Myers and Leslie Junkin and Alicia Westbrook to help. It should be easy. Now, I made a lot of personal comments, but as a developmental pediatrician who's practiced in the state for, 38 years now, I have a lot of experience and I care about our kids. I have 10 grandkids and a vested interest in making this state great in the future. All right. I'd love to hear other comments, thoughts. We have time.
I have a comment.
This
Can
is
you all hear me
Dr.
okay?
Walker. Yes, Dr.
Yes.
Walker.
So I just wanted to emphasize, or I guess clarify that I know that the pandemic brought on a lot of issues for the early intervention system, but the issues that we're talking about today are long-standing and were just made worse by the pandemic. These things existed before that. So I think we should keep that in mind, that the pandemic didn't cause these issues. It's been long-standing. The other thing I wanted just to piggyback on with what you were saying, Dr. Buttress, and with Denise's testimony about equity, I've heard a lot of variation in access to services through this testimony, and I would be willing to bet that variation is influenced or moderated by geographical location, as well as maybe potentially socioeconomic status of the family, and race and ethnicity as well, possibly language too. So if we could get some evidence or data about equitable access to services, so are some parts of our state, do they have less access because of their geographical location or something like that? I would venture to say yes, probably, but I don't know if we've seen that data in real time. So I think that would be helpful for this task force to look into, if that makes sense.
Okay, thank you, Dr. Walker. Mary Claire and Emily are nodding. They can certainly do that. So they will work on that.
Dr. Buttress.
Yes.
Yeah, I will introduce myself. I'm Dr. Tanya Fitz. I'm a pediatrician in Oxford, Mississippi, and very much like most of the people on this call, I've also had interaction with the early intervention services, both as a pediatrician and as a mother. And when we're talking about having services in home or in where the child's environment is, it's so very important to have that. My son needed both occupational therapy and speech therapy that started when he was around age 2. It took us 3 months in Lafayette County to get that evaluation done and therapy started. And that was now 7 years ago. So I will echo Dr. Walker's sentiments that this is longstanding issues that we've been having. He was able to get speech therapy in home, but he was not able to get occupational therapy in home, which involved us taking off and having to take him to therapy every week. And also, Dr. Buttress, we'll be looking at the transitions. Is that correct? Are we looking at the transition from early intervention into the school district or not?
Yes, we'll look at all the way through the early intervention service.
Yeah, and the transitions are often really bumpy. I have patients who are from Marshall County and Tate County, and there are no providers, and they are driving to Oxford to get their therapy services. So I do agree, Dr. Walker, it is probably geographical, but also even in the well-serviced areas, the barrier to getting services in their natural environment is really high.
Thank you, Dr. Fitz.
I have a comment. This is Keith Buncannon with Caring Hands Rehab. And we're a service provider in Northeast Mississippi. And we strive to serve in the natural environment. And I noticed that some that have spoken today mentioned that having the therapist as employees in the health department. But one issue with that I see is that the health department is now considered a non-natural environment. And we really strive to utilize the natural environments for the children. And in our area, I would say that we're probably 70% in the natural environment. But we're fortunate to have a large group of therapists. And I just wanted to point that out.
Thank you, Keith. Yes, I appreciate the work that you and your group does in early intervention.
Dr. Buttress, can I add to that? Thank you. This is Sarah Myers. And thank you, Keith, for sharing that point. I have not met him personally, but I've heard these therapists are doing a fabulous job in that region, making sure they provide those services at home, which is very difficult for folks that, as you spoke to, are in an outpatient model because of the productivity requirements and cancellations and things like that happen naturally in pediatrics. But to expand and explain on that thought, most certainly hiring providers to work within the health department is not so that they provide services in the health department. It is just to provide a consistent job, a position, a full-time position, so that those providers have easy access to each other and collaborate with the service coordinators, and they are trained and understand EI, and they also understand their own practice requirements in the medical homes needs, so that they can then go into those natural settings in their region and provide services. So yeah, thank you for that, Keith. That was a good point.
Right. As we continue to hear, one problem that contracted service providers have is that the billing process and collections can take a long time. Most of us in the health profession and allied health profession, we're not trained as business people. And so many times it's sort of a losing proposition to try to be able to have a practice such as this, where you have to build insurance, then Medicaid, then early intervention. So I don't know if anyone else wants to speak to that, but it seems to me very difficult. And so I think that the comment from Dr. Myers was one that there would be individuals who would be employed. And I know that type of setup exists in other states. We've seen that in several other states. You know, a hub model that has been brought up, I just want everybody to know that we're still looking at everything, and no decisions are made whatsoever. The hub model was mentioned as a place that could be one that could employ individuals. So what that could mean is that it could be a university hub model, it could be a private hub, it could be a hybrid where you have university and private hubs who have what it needs to operate a billing system, to employ individuals, and to do good oversight for those individuals. As we've already heard several times, there are some service providers who are incredibly wonderful, and there's some who are not. And so to try to have good standards across the board and make sure that adequate services, not just adequate, but robust services are given to all children. So with that said, even if I'm throwing this out there, because these are thoughts that have come to me since we have to, at some point, start coming up with some solutions. If you have that hybrid hub model that I just mentioned, some institution, some group, there has to be some major entity that oversees it. It's the health department right now is oversighted. Should it continue to be the health department? In my opinion, this is my individual opinion, and I want to hear from others because we need to hear. I'm speaking as an individual, please, not for the task force. My opinion is the health department's a good place for it. I think it seems like an obvious place because in early intervention, in that birth to 3 period, you cannot separate out education and health. It is all one. It's early brain growth. And so if, you know, I know there are a few states, and Emily has done some great work on this. There are a few states where early intervention is housed in the State Department of Education. And you know, it may be very, very well done. There's got to be a link back to health and allied health professionals. And I know education can do some of that, but you hear where the referrals are coming from. The earliest referrals should be coming from physicians, nurse practitioners, and then others, you know, who have discovery. And so we want to keep that link. That's my opinion. And so I'd love to hear from others about that. This is Biz Harris.
Yes, I'm sorry. This is Biz Harris with Mella. I don't know that I have an opinion about. I don't have an opinion about where it should be housed. But I do, but it made me think of a map that CCAC created or had created, the landscape analysis of all the different programs interacting, you know, that interface with young children. And it looks a bit like a bowl of spaghetti was dumped over. And so one, I would love maybe to, I know you mentioned CCAC is going to come and present their early intervention, y'all's early intervention working group is going to come present your recommendations. But I also think it would be really valuable to hear those landscape analysis pieces from around early intervention from the CCAC report that you published, what, last year? I think that could be, and there was a strength and opportunities document that I think is really valuable. I mean, it's a lot of what we've already said, but I think, it's just so concisely packaged. So I think that I would love to hear that, from them. And then, my other question is, the reason I say that is because I wonder, in keeping things separate, does it make it more complicated for families to know what's available and what's out there? And I don't know, but I think about that, the squiggly map I've seen. The other question that I am wondering about, and this is just because, as I mentioned, I focus on grassroots advocacy, is that I don't know if all the committee members also understand how how reimbursement and how payment works. How do people, how many people are paying out of pocket for services and how many people are using First Step? So I'm wondering about some data around the financial process.
So Emily's saying she doesn't have any specifics on that right now. Dr. Edney has, I think Dr. Edney had to sign off, correct? It looks like he's gone. Dr. Edney has said that he would be happy to help us in any way, any data, so we can ask about that. He said as long as it's okay with the feds, he's okay with it. He's willing to share and he wants to make our job easier. But that's a really good question. The way the reimbursement works, in general, like I said, is it's up to the individual contracted providers to bill for the service. And it can be very circuitous, difficult. The other thing that I want to mention is, before services can be imparted, a plan of care has to be submitted by the provider. Sometimes there's confusion as what provider? Is it the subspecialist? Is it the primary care provider? If they don't have a primary care provider, many times the subspecialist who sees a child maybe once a year or maybe just one time, things get hung up. So there must be a better way. The other piece is these forms are faxed. There is no electronic method. Now, people say you have to fax to keep privacy. That's not entirely true. And as you know, a fax number can be busy, it cannot work. Papers can get under copied papers and the like, and that has happened and does happen and will continue to happen in big office. So is there any way? The other thing is there is no electronic referral process. So that's very cumbersome and somewhat, in my mind, even for an old person with gray hair sitting here, somewhat antiquated. And so there are several pieces and parts that the mighty system doesn't interface with other medical systems like Epic, which we use Epic and a lot of places do. And Epic, you can interface at least to see if a visit has happened, but the mighty system does not. So for example, when I go down to the coast and I see patients in Biloxi or Bay St. Louis, I can look on the chart and see that patients went to Singing River for their interventional services. I also know that those are individuals who were privately referred probably and receiving services not through the early intervention system, but through that private referral. And I see that a lot. So I can't see anything about what's happening with early intervention. And that is frustrating to providers when you're trying to track. And so having real-time information is possible if we could just make sure that gets done. Yes.
Dr. Buttress. Dr. Buttress.
Yes.
Hello, this is Carlin Hennington. I am a representative of the Mississippi Association for Psychology in the Schools. I'm a school psychologist. I've been a part of First Steps here in Mississippi for about 25 years. And what I wanted to add to your list of information that I think we need, I wrote down reimbursement and understanding that from a provider perspective, as well as some of the things that Dr. Edney talked about. I'd also like to add to your list of what we need is someone to present on the laws, the similarities and the differences between, say, for example, and I wrote something in the chat box, HIPAA, and then also FERPA. And then in addition to that, Part C law and what is required under Part C from the federal government. I think it would be remiss to make decisions without thoroughly understanding what the constraints are that the law might have on any plans that we have.
Thank you, Dr. Hennington. Those are great suggestions, and we can certainly work on that. Yes.
Yeah, in fact, I do believe that someone perhaps from Part C, from First Steps, might be an appropriate person to consult. Even though I'm a school psychologist and I understand school law, I don't live it every day. I have to understand Part B as well as Part C, and I don't do any of the reporting for the requirements. And I think that's also important.
Thank you. We'll certainly move forward on that, and perhaps that would be a good additional piece to add to our August meeting to go over that further. There are basic federal requirements for Part C, and then the state has the ability to set up their own guidelines. So there are minimal requirements, and then their state, their minimal Fed requirements, and then their state. So we'll need to look at both of those. Yes.
This is Katie Cassidy. I was just going to speak to how it works for me as a provider. Hopefully that'd be helpful to talk about the billing. It's not the same, so I want to make that clear. Like Keith is on the call. I've heard him in several meetings where he's a different kind of setup where he's running the billing portion, I believe. Correct me if I'm wrong, Keith. And then he's hiring the therapist to provide services. So for me, I am that one person. It's just me. And so initially you have to get credentialed with all the different insurances. So each one of those processes is different. For example, I struggled with Blue Cross because they require a brick and mortar place of business to be in network. So I don't have in network with Blue Cross. So it hasn't really come up with me yet, but if I do get a referral from a service coordinator who's a child that wants to use their Blue Cross, then I wouldn't be, even if I'm available, then I wouldn't be able to provide services to the Blue Cross. So then that can get into, you know, well, then does that switch over to the payer of last resort, and then am I paid by First Steps grant funding? So that's the insurance piece, and then I am credentialed with Medicaid and the various Molina Magnolia versions of Medicaid. And so if a child and their family decides to use their insurance, then that's a different really process and payment for the therapist than it is from the payer of last resort. So if I am paid by First Steps, that's a higher rate now, and that's the rate that's incentivizing that home visit. So as far as I know, that doesn't exist if your insurance is the same rate wherever the service occurred. I hope that was helpful. I am really interested. Dr. Edney talked about this pay and chase model. That's the first time I'd heard about that. So I don't know if it's possible for us to get more information on other states or groups that may be using that. Sounds like it would just flip that process from the provider to the health department. And I don't know, I'm sure that requires more funding, but I don't know if there are other requirements that the health department would need to facilitate that.
Thank you so much, Dr. Cassidy. Yes, the pay and chase is intriguing. It is. That was one of the reasons behind some sort of hub model. Hybrid is that you have billing systems already set up so that individual will continue to get paid, wouldn't have to wait for a month or 6 months to get paid. Be paid. So we'll certainly look more at that. You can tell Dr. Edney was in private practice by the pay and chase comment. Any other questions or thoughts?
This is Denise Powell, just going back to the point about having a central hub through the Mississippi State Department of Health. I think that's very reasonable and great if it's been working. I think the biggest thing is just making sure that outreach to different geographical areas and ensuring like people know who the point of contact is. I might be speaking on something that's already done, but I know here on the Gulf Coast, like I know who to reach out to if a family is having issues. And that kind of thing, but it did take me a second to find that. So I think there could be more clarity on like, if you're in the Delta, who would you reach out to? If you're in Central Mississippi, who would you reach out to? So that way everything's localized in Jackson, but you definitely know who those points of contacts are. And maybe just having updates when there's turnover so that us as providers can also know how to handle that if things arise with families.
Thank you, Dr. Powell. There certainly, Dr. Edney mentioned this, and I mentioned this in the beginning. We're also would like to look into the numbers of children served as to the numbers of children who will likely need to be served. We know that living in poverty increases the risk of needing early intervention services. We know that our infant mortality rate and infant morbidity rate in our state is very, very high. And so we would like to also, I would like for us to, and I'd like to hear from the other task force members at the eligibility criteria. That's another complaint that we've heard from providers. They quit referring because they knew a child needed intervention, but then they were ruled ineligible because our eligibility requirement meets federal guidelines, but it's you have to have at least a 33% delay in one area or a 25% delay in 2 areas. And to speak to Miranda Carter's comment, in under a year, you have to be very significantly delayed to meet that criteria. And so if you're not, for example, if you're not sitting alone at 8 months or even 9 months, you don't have a 33% delay yet. So to cone down on the eligibility criteria would probably be a big deal. the number waiting for 6 months for a 18-month-old is a long time in their life. And so we need to make sure we're thinking through what we're doing. If we do that, it increases significantly the number of children who will need to be served. And so, again, that will increase the amount of money needed. There already is not enough money. So as we are coming up with recommendations, we've made it clear, I think all of us have on this task force, that leaving things exactly as they are, probably not what we need. We don't need to just add more money, but what would make services better? If we make services better, we have to commit that there needs to be more money, and then to commit how much more. I have a number in my head, but that's my number, and so I think the task force will need to come up with recommendations. Right now, we are serving around 1.2% of children from birth to 1.5%. We should be serving at least 10%. And that would be my goal to get to. One of our psychologists has recently said that number probably is more at 20%. If we really want to have kids ready to learn by the time they enter pre-K or kindergarten, our legislature has seen clearly the benefit of the pre-K collaborative. They continue to increase funding. I think you guys have heard this, but about what, 44 million is going into the pre-K collaboratives. Yeah. So if we really know that the bulk of the brain develops in birth to 3 period, then we need to think about that. The earlier the better. Any other comments or thoughts or needs that you want the task force to take on?
Dr. Buttress.
Yes.
This is Representative Velcher. First of all, thank you for being willing to serve as chair, and thank everyone for serving on the task force. I haven't heard anything brought up, and I read it from a lay perspective. I want to see if someone can give any lend any kind of credence or knowledge to this on the state performance report that you can pull from the health department. And looking at the numbers on timely provision of services and service in natural environments, we've gone, according to the report, from in the 90s down, consistently dropping into the 80s. And I was wondering, and this, someone brought this up earlier, this long precedes COVID. Our numbers have been dropping to meet that target goal. Can anyone lend any explanation to why our numbers have consistently dropped over the years?
Yeah. Thank you for that question. The comment from Emily, and this is what little I know, is you're correct. The numbers have dropped, but we don't know exactly why, other than the issues that we brought up, the difficulty in billing, the difficulty in providers, the fact that some providers have trouble getting credentialed and just decide, never mind, I'm not going to do this, it's too hard, and go work for a company or a hospital or an entity. And so, unfortunately, something that I've seen over the years is many times people who really wanted to work in early childhood end up not adults aren't good too, but end up working with adults instead of children because the money's better. It's easier. And so I know you can feel very dedicated, but after a while, it takes a toll on you. So,
Dr.
yes, Dr. Hennington.
I wanted to remind some folks and inform others that OSEP, which is the Federal Office of Special Education programs, requires the state to regularly report on a number of indicators. Some of those indicators are provision of timely services, provision of services in the natural environment, time to implement the IFSP, time to make sure that the referral is addressed within a timely manner. The same sorts of laws are dictated under Part B, but the indicators are more specific to provision for services children. And so, having said that, I happen to be chair of the State Interagency Coordinating Council for First Steps, and we get regular reports at that meeting regarding the indicators. It breaks those indicators down by specific areas in the state. There are some areas in the state that consistently struggle with things like timely service provision. And one of the things that the state ICC does is it keeps its eye on various areas that are below our requirements set by the federal government. In some cases, it's set by them. In other cases, the state sets our requirements. And so it's not quite correct to say that it's consistently gone down. We've had some real improvements in some years post-COVID, during COVID. We've had some significant challenges, as you might imagine, service provision, natural environment, that sort of thing. And so the numbers have gone down in some areas. During that time, they remained constant in other areas, and there has been some improvement in recent times. And I think Dr. Edney spoke just a little bit to that, but the First Steps program can provide a wealth of information that will show the actual data with regard to some of the things that people are asking for. And then in addition to that, the demographic challenges and the diversity equity issues that were brought up earlier with regard by Dr. Powell with regard to certain areas and certain populations, it's hard to say, but certain areas we can definitely track that through the information that is given, could be obtained from the report that the State Interagency Coordinating Council puts together, as well as that annual report that must be submitted to the federal government by First Steps program. So we have data, and we have some data that would be very useful and should be relatively accurate. Not all data is perfect. As a scientist and a university faculty member, I can tell you that data is only as good as a collection mechanism for that data. And there's always a plus minus error confidence interval with any data. But we can trust that data because it is submitted to the federal government and therefore subject to scrutiny.
Dr. Hennington, I think I had asked that question, do we know the quality of the data? Because in my experience in working with state agency, data is not always the best at the state agency level due to a lot of different factors. And so I would guess I would like to know more about who's collecting it, what system is that being put in, because I understand that some of the providers who utilize the Mighty system don't utilize it maybe all the time because it's a very complicated system. And so is the data coming from the Mighty system? Is it coming from the coordinator? What does that input look like? And that might just be helpful and just my understanding too of what those what the quality is.
Again, I would say the expert in the world would be the Part C folks and having them report their data, some trends, and we can identify the length of time we want to look at those trends, what's going on. We can identify specific indicators, we can identify all the indicators, and then we can have them present on the Mighty system that will tell you about the strengths and the challenges with that system and collection of data within that, and perhaps even some of the things that First Steps has done to address some of those shortcomings, because they're certainly aware that there can be shortcomings and attempt to head those things off. Again, I'm not speaking for Part C per se. I'm a school psychologist, so I'm speaking from that perspective. But on the other hand, I've been in early intervention from the first implementation under Roy Hart, where we did have a hub model, through the ups and the downs of early intervention. I've been a service provider. I've done the assessments. I worked in the hub model, and I also am the parent and the grandparent of neurodiverse children. And so I experienced it from the personal side of things as well.
Dr. Hennington, I'm with you. I was here in the Roy Hart days also.
Yeah, I remember I attended a lot of your trainings.
So thank you. Thank you for all of that information, and thank you for staying in Mississippi and continuing to work here with our children. Okay. So maybe for the last few minutes, we've got about 33 minutes, and I might be able to give you all back a little bit of time. I think we've gotten a lot done, gathered a lot of information, but there's certainly a great deal more that we need to do. One thing that I would suggest as we're thinking through this, Mary Claire and Emily did a good job of sort of separating out issues. And if you'll see on the agenda, as you're thinking about putting your thoughts together, we want to look at the structure of the early intervention infrastructure, the billing and the reimbursement processes, the referral and access to services, and then the service providers. And so if you could separate those out, I think it would help us as we're collating information. And as people are sending in comments, I think you all know that there is a email for public comment. And I don't have that form. Mary Claire, go ahead and get that if you will.
Yes, we have the early intervention email. It is just simply earlyintervention@peer.ms.gov. And we've already gotten some comments, but if you could continue to share that, it would be really great to hear from some more providers and parents on their experiences with early intervention. We gave them to August 1st, so our hope is to share kind of a summary of what has been submitted with you all at the next meeting. But if you think we should extend the August 1st deadline, we certainly can, if you think that you can continue to share and get good information.
What do y'all think about that? Do you think we should extend the period, or do you think that's long enough? I know we've disseminated it to several groups.
I will say we've gotten about 12 people, so I feel like we could get, I feel like we could reach a lot more than 12, so.
We just had our quarterly state ICC meeting. This is Carlin Hennington. And a significant number of people were unaware of that address. So I put in a request to put it in the chat, please. And because I've heard that from folks who are vested in early intervention services, keeping that open a little bit longer might be a good idea. 12 people is not very many when you think about the sheer numbers of providers, parents, and other individuals.
I agree with you. Feel free to send that out, Dr. Hennington, to the SICC. We did to CCAC, and I think it's important to encourage all others. We want to hear, we cannot come up with recommendations that will make 100% of people happy. But what we can do is to try to make sure that we're listening, hearing, and collating, and doing the best job that we can.
This is Kenya Wolf from the University of Mississippi. I also would like to disseminate this specifically to childcare providers. I feel like that is a voice we've heard many voices today, but I just want to, as a former childcare director who often sees this on a daily basis, I just think that their voices would be really it'd be remiss if we didn't hear theirs. So I'm happy to send it out from, the state networks to our childcare providers, both family and center directors.
So great. That sounds like a great idea. And we have sent that flyer out to this group. We will send it again. Mary Claire, if you will do that.
And if y'all have anyone you want me to send it to, please let me know and I will send it out to them as well. And we were, Ted just asked me how long do we want to extend it. I was thinking until September 1st, but if that's too long, y'all can let me.
I think that's a bit long because we need to start collating our report. So I would say it's, this is the 24th. If we extend it until August the 7th, I would hope that people will go ahead. So if is that okay? I really,
So yeah, that's fine.
yeah, that should be enough time if we can make sure that you all send it out today, tomorrow, in the next couple of days so that we can gather that. To us, we don't want to just get comment in, but we want to pay attention to it, make sure that we've collated it, and then to give us enough time as we're moving through the next 2 or 3 months, we've got to have our report ready for December.
I would just like to add if you all have been, you gave us great questions today, but if there are other questions that you want answered, just email me, let us know, and we will start looking into that.
And is Dr. Heather Hannah on? I know she was.
I am.
Hi. Heather, Dr. Hannah and I have been working together for a while. She's at the Social Science Research Center at Mississippi State. And Heather, I would like to, I don't know if I said this out loud, but I would like to request that you next month at our next meeting also, there have been some requests about some of the data that's been coming in, that's available, that about the resources too, and your group has been taking care of our Mississippi Thrive website and continuing to monitor that and have the resources there. And if you could perhaps make some comments for us next month also, I'd really appreciate it.
Sure, I'll be happy to.
Thank you. Is there anyone else that you think we really need to hear from? If you
No.
do, go ahead.
I really thought that Randy's testimony was very helpful. And so if we could get more parent testimony too, I think that would be excellent.
If you have any identified that you'd like to hear from Dr. Walker, that would be great, or anyone else.
I can find some, I'm sure.
All right. So our next meeting is August the 14th. That would be at 11 a.m. And how long will the meeting last? We may need to schedule it for an hour and a half if we're going to try to cover a few things. And what we'll try to do is keep none of the meetings any longer than that after this one. We just felt like we needed to get this testimony down. And should we go ahead and start looking at our next meeting for September? I know September, we talked about trying to meet at least once a month, but perhaps need to meet more often. And I am hoping that we could perhaps get back together fairly early in September, but obviously not that first week of Labor Day week, I guess, unless we did it toward the end. Does anybody have any? Do you want to speak out about days, or do you want a doodle poll to be sent out? Doodle poll. Okay, we'll do that. So hopefully we'll have that settled before our August meeting. Any other thoughts or comments? Okay, well, we'll adjourn. And I want to thank everybody again for your time and commitment to this.